So this is again a painful stiff shoulder. This 66-year-old lady had pain in the right shoulder for 3 years. Associated stiffness was there, and there was no significant trauma to the shoulder. Was again labeled as frozen shoulder, and she had been treated by manipulation under anesthesia, injection, steroids, and some physiotherapy. The pain increased for last 1 year when she presented to us.
So please adjust your mic. Your mic.
Near close to your mic.
Is it working?
Pass me bol.
Okay. She was a diabetic and hypertensive. She had bilateral TKR done after an early failure of STO. So we suspected that she had some rheumatological disorder, but consultation showed that they couldn't make a diagnosis for it. And she was taking 2 tablets of analgesic daily when she presented to us. On examination, motion was severely reduced in all directions, both active and passive. Flexion 0 to 50, abduction 0 to 40, and internal and external rotations were just minimal. And attempted movements were painfully limited, and there was no distal neurovascular deficit. And these were the X-rays, which shows joint space reduction and osteophytes on glenoid and humeral head. So this is osteoarthritis and not a frozen shoulder. CT scan again showed osteophytes on glenoid and humeral head, both anterior, posterior and inferior, and there was joint space reduction. A 3D recon again showed the presence of osteophytes all around the humeral head and the glenoid, and obviously joint space was reduced. MR showed intact rotator cuff. So what's your plan in this case?
So
66.
can we have the options on the screen?
Do you have the option on the screen?
We have these options.
We can have this.
So
Yes, sir.
So we can have the raise of hands. I think it's not an ARS question. So how many of us will go for injection and manipulation with physiotherapy? Raise your hands.
None.
None. So hemi replacement. Total shoulder anatomic. Few of them, 5, 6. Reverse. Most of them.
Most.
Anybody for none of the above?
We have to do something.
Okay.
That's not the option.
So that's the areas that have been taken care of. So what we did was, we did an open debridement for this patient. We used a deltopectoral approach in supine position. We detached the subscapularis from lesser tuberosity, capsular release from humerus and glenoid, osteophytes and loose bodies were removed, and microfracture was done at complete cartilage loss sites. This is the immediate post-op X-ray. Pendulum exercises were started, shoulder shrugs, elbow and hand exercises, and after 8 weeks we started the active and passive range of motion exercises. Can you tell us what is the expected range of motion after this on function?
If you are presenting, it must be good.
It must be good. Okay, so that's the answer by exclusion. We have a CT. We showed you
Yes,
CT.
scan.
Okay. So these are X-rays after 13 months. This is post-op MR. Cuff is intact. How do I play the video here? Can you play the video? Video. Okay. So this is the right shoulder we had operated. Range of motion increased dramatically, but it was not 100%. Pain decreased. She didn't require any analgesics, could sleep without pain, and her activities of daily living improved. Her external rotation was limited. Probably it was intentional. I repaired the subscapularis in internal rotation.
So, sir, what was your thought process in planning this surgery
Yeah.
in such
Okay,
kind of a
okay.
case?
I'll tell you. Now these ladies need more of internal rotation for their dressing and care of hair. So internal rotation is more important for these patients rather than external rotation. They don't require external rotation for any activities.
Sir, mic clearly.
I agree.
Without external rotation, they will not be able to reach their hair or scratch their back or do any meaningful activity. Technically, if you ask me, this is the most useless movement because there is nothing achieved by this. You want to pick up something, put it down there, you need your rotations.
She was
A
able to
knee-
do that.
She will do that by turning around like this. But you can't turn around and go down there, or you can't turn around and do that. The advantage of shoulder joint is the rotations because it's a ball and socket joint.
But she can do, you can see
In
the internal rotation, she can reach her back,
Yes,
she can
I
reach her
agree.
head.
But the advantage of the shoulder joint is rotational movement. When you have osteoarthritis, you cannot get rotations
Okay.
because it's converted into a hinge joint. You have done a good job, she has achieved movement, function cannot be achieved because pain will remain because we've not burned any bridges. The pathology is still there.
You said pain will remain.
Yes, because
She is off analgesics.
I agree, she'll come back.
And
How
she
long
is
is that going to
She is a
last?
mother of an orthopedic surgeon himself.
She will come back because your disease has not been treated. The disease is still there.
I agree. See, X-rays look bizarre, CT looks bizarre, MR is also not normal. So that's what I want to emphasize. You can do things without arthroplasty also. That is the whole message.
Ravi,
Why would I not do a reverse shoulder on her?
Ravi, what was your
Why
diagnosis?
should I do a reverse shoulder? I can never achieve this movement by reverse.
Oh, I don't think.
Ravi,
The
what was your
question is
diagnosis?
what he asked. What went into your mind before you did this? Now you're brave, you're fine.
Okay.
But what did you tell this doctor or his whatever son?
Was the
that
patient
this is what I'm
against
going-
it? Was the patient adamant and against this surgery?
No, patient was not.
So first,
In fact, I had reverse shoulder on table when I was operating.
Ravi, what was your diagnosis? When you went in, what was your diagnosis? Like what is
Diagnosis osteoarthritis. We couldn't make a diagnosis for rheumatoid or any other rheumatological disorder. It was osteoarthritis.
Can I ask a
but
question here?
debridement is then a temporizing method, which
But-
we don't know how long it will
But
last.
since both her knee joints were operated quite early, even HTO failed, so I thought this is a rheumatological disorder. And we have been treating rheumatoid elbows by debridement. And the X-rays looks horrible, but the patient is happy after the open debridement. We have been doing it both arthroscopic and open debridement. Osteoarthritis elbow, open debridement, patients are happy, X-rays are horribly bad.
Sir,
So upper
do you
limb
have series
osteoarthritis
of
is
patients,
different
sir?
from lower limb osteoarthritis. That's the message.
Ravi, do you have other series of patients
Or is the
also
only case?
similar
I have
like
done
this?
I have done one more patient who was not so bad, but he had osteoarthritis. Chairman of the railway board. He's happy without osteoplasty.
Ravi, can I ask you one question? Did you here I am here. Did you do it to buy some time so that you can plan a reverse or something like that later?
Yeah, that's what I'm coming.
Okay.
So it's a joint preserving procedure. You don't burn any bridges. It delays or avoids joint replacement and all its complications. It can be done arthroscopically, theoretically, but when you have big osteophytes, severe joint space reduction, you can do it open. And we don't know the very long-term results. If you look at the literature, we don't have any recommendation for shoulder osteoarthritis as of 2022. No scientific organization has given recommendations for shoulder osteoarthritis. So it is just by hearsay, I want to do this, I want to do that. But there is no randomized control trial to suggest medical treatment, surgical what treatment is good. There is no recommendation. Now I could find in Journal of Arthroscopy, arthroscopic debridement, excellent outcome in early radiographic stage of osteoarthritis. Unsatisfied people were there when the cartilage grade was more, and they found, 80% good to excellent result. And these are some very big names in shoulder surgery. Very big names. Grade 4 also there. Grade 4 is also there. No, sorry, you read it wrong. 80% good to excellent. If you go here, even good is in grade 3. 9 good results in grade 3. Excellent result 1 in grade 3 and 4 also. So more reports were there in 2007, 2008, 2012. They said joint debridement, capsule release and humeral osteoplasty with axillary nerve release gives good results. Even Journal of American Academy of Orthopedic Surgery, JAOS, described this as a review article, this procedure as a review article. And they said in selected cases you can have good results. Now this paper described conversion to arthroplasty after debridement. And they said that 32% had undergone arthroplasty at a mean interval of 26 months. So around 68 did not opt for or did not need arthroplasty. So that figure is a big figure. So French group. So even if the French are talking, who are supposed to be the gods of shoulder surgery, they said that arthroscopic debridement delayed arthroplasty by 3 to 4 years in 56% of cases. This is a very recent article, 2022, arthroscopy. This is 92% survival at 1 year, 85 at 2 years, 77 at 5 years and 63 at 10 years. So one should give a serious consideration to this procedure. Don't be carried away that everything osteoarthritis means arthroplasty. Like you have HTO in knee, you have something in shoulder also. That's the only message that I want to carry. Thank you.
Thank you, sir, for this wonderful talk.
And there is no report of open release. I did it because it was severe. I couldn't put in a scope in this case, and I can't do a 360-degree osteophyte release by arthroscopic means. My early results are good. I've done 2 cases, and the message I want to carry is that the upper limb osteoarthritis is very different from lower limb osteoarthritis. Even if you have severe joint space reduction, cartilage loss, the function can be good. Function can be good. Thank you.
Thank you, sir.
Thank you, sir.